I'm Councillor Lucia Desneves, for those of you who don't know me, and I co-chair this meeting along with Councillor Jogi. I am the chair of the Health and Wellbeing Board and the Cabinet Member for Health, Social Care and Wellbeing. And Councillor Jogi will introduce himself when he arrives. So just to remind you all that you should note that this meeting has been recorded for live and subsequent broadcast via the Council's internet site. So let's start with welcome and introductions, and I'll start with still a few people arriving, and I will start with people, as I said, on the council side, and that might help things. So Joe, do you want to go first?
Good afternoon, everybody. My name's Joe Benmore. I lead on community safety and offender management for the council.
Thanks, Joe. Mike, do you want to go?
Yep, Mike Hakata. I'm Deputy Leader of the Council, Cabinet Member for Climate Action, Environment and Transport.
Thanks, Mike. Okay, and let's go to Beverly.
Hello, Beverly Tarker, Director Adults and Health and Communities.
Thanks, Beverly. Will.
Will Maymaris, Director of Public Health, Haringo Council.
Sarah.
Sarah Hart, Senior Commissioner in the Public Health Team for Substance Misuse, Sexual Health and Health Improvement.
Thank you. Susan.
Susan OTT, Assistant Director of Public Health, and I'm the Public Health Consultant Lead for Drugs and Alcohol, hence why I'm attending today's joint meeting. Thank you.
Lovely, thanks, Susan. I'm just going down the list now. Manju.
Hi, I'm Manju Lutman. I'm the Violence Against Women and Girls Strategic Lead and Commissioner in Public Health.
Thanks, Manju. Chantal.
Hi, I'm Chantal Fitania, Consultant in Public Health.
Jeffrey.
Jeffrey Rosen, Chief Executive, British New York Trust, Voluntary Sector.
Thank you. Eduardo.
Eduardo Arujo, Haringey Community Gold, and I'm also a Senior Tottenham Community Safety Manager.
Thank you. Zoe.
Hello, I'm Zoe Robertson from Public Health.
Thank you. Sabran, do you want to introduce yourself again?
My name is Sabran Bibi. I'm stepping in on behalf of Latoya Ridge, who's the Operational Manager for Victim Support. My role is a hub manager that covers the North area, and Latoya is my line manager. So I do send apologies on behalf of Latoya, but I'm stepping for the first time to this meeting.
Thank you. Shirley.
Good afternoon, Shirley Kenton, Head of Service for Enfield and Haringey Probation Service.
Thanks, Shirley. Judith. Oh, we can't hear you, Judith.
Sorry about that. Hello, I'm Judith During. I'm the Assistant Director for the Housing Management Service.
Nice to meet you, Judith. I don't think I've met you.
We haven't met yet.
Okay. I might have met. Oh, Seb. We've got Seb here.
Afternoon, everyone. Seb Adjiado, Met Police and Head of Public Protection. I've been invited today by Joe just to give any input on DA, but I'd ask for your apologies, just bearing with me. I've just recovered from COVID, so I'm a bit out of it at the moment.
Sorry to hear that, Seb, but nice to have you with us nevertheless. So thank you. Thanks for making the time to do so. I'm just checking who else I've missed. Have I missed anyone else? Councillor Brabazon, Dina, even.
Thanks, Lucia. Hi, I was just getting a fan. Yes, my name's Dina Brabazon. I'm Cabinet Member for Children, Schools and Families. Sorry for a bit of lateness. Apologies.
That's it. And I have missed a few people. Hubert, I don't know if you managed to get hold of Councillor Jogi, but could you introduce yourself?
Thank you, Councillor. Hubert Malcolm, Interim Director of Environment and Neighbourhoods, and I've left the message for Councillor Jogi. I'll keep trying.
Thank you. Jonathan?
Good afternoon, everybody. I'm Jonathan Watersfield. I'm a Chief Inspector for Neighbour Policing, looking after Haringey, so here to support from a police perspective. Anything I can add?
Thank you. Thanks very much. Have I missed anyone else out? Sorry, you have to raise. It's such a long list, and I didn't go in order. So, is there anyone I haven't asked to introduce themselves? No. Okay. Oh, Sandy.
Hi there, Sandy Broker, intern analysis within the community safety team.
Thank you. Oh, and Simona, do you want to just introduce yourself? Apologies.
Hi, my name is Simona. I'm currently a GP hub specialist at Haggart in Tottenham, the alcohol service, and I also do sober coaching in a private.
Thank you. Oh, and I see Christina. I missed you as well. Apologies.
That's okay. Hi everyone. Christina Andrews, Strategic Lead for Communities and Inequalities at the Council.
And then, thank you, Christina. Hanson Bay, or is that the surname? Apologies. My sincere apologies.
That's my surname and first name Laurie. All the people's reference group, Safeguarding Adults Board, Hornsey Pensioners, and Untitled Chapter.
You're very faint, I'm afraid. We can't hear you very well. I don't know if there's anything you could do at your end. I'm not sure.
I'll try again. Can you hear this?
Oh, much better. Thank you.
Okay, I'm Older People's Reference Group, Hornsey Pensioners, Safeguarding Adults Board, one or two other boards, Neighbourhood Watch. That's it.
Thank you very much. Thanks for joining us. Okay, so that's the intros and what big group we are. It's good to see everyone, so thank you for making the time. Dominic, do we have any apologies that you're aware of?
Yes, we do, yes. So we've got apologies received from David Archibald and from Caroline Haynes, also from Latoya Ridge from Victim Support, and also Lynette Charles from Mind has given notice that she'll be late to the meeting, but is expecting to join us later on.
Thank you, thanks very much. Okay, and items of urgent business?
None received, Chair.
Thank you. Declarations of interest, anybody? Okay, let's move on then. Thank you. Dominic, do we have any questions, deputations or petitions?
No, none have been received.
Thank you. Okay, so we'll just take the minutes of the last meeting. Are there any comments or queries? So the last meeting was in December 2021, and doesn't that feel like a long time ago? Any comments or questions? I suspect there's been quite a lot of progress on a range of things between now and then. No? Okay, thank you. Well, I'll take those as read and accepted in that case. Dominic, I'm assuming we don't have any new items of urgent business?
No, we don't know.
Thank you. And apologies, Dominic, I didn't get you to introduce yourself. Will you just introduce yourself to everyone?
Oh, right, yes, I'm Dominic O'Brien. I'm a scrutiny officer. I'm just covering this meeting today on behalf of Democratic Services.
Thanks, thank you very much. Okay, let's go straight then to item 9 on the agenda, the National Drug Strategy from Harm to Hope, a 10-year drugs plan to cut crime and save lives. So I believe this is on pages 11 and 28 for you all. And I think Joe and Sarah are going to introduce the item.
Thanks, Chair. Sarah, I'll share the presentation. I think is that, or Dom, have you got a copy of the presentation, Dominic?
I do. Yeah. Do you want me to put them up?
Yes, please, if you could. Thank you.
Yeah, we'll do.
Have we lost Sarah?
No, Sarah's here. I can see her.
I think she might have frozen. Hi, Sarah, can you hear us? Shall I kick off?
Yes,
and then
please,
Sarah
Will. Thank you.
join and just start framing. So just to reintroduce myself, I'm Will. I'm Director of Public Health, and Joe and Sarah are going to do the presentation with me. But this is actually a really significant piece of work, and that's why we wanted to bring this to the Joint Community Safety Partnership and Health and Wellbeing Board. So drug-related harms have been a significant issue nationally, London and Haringo for as long as we can remember. There's a kind of policy shift now where that we've got a national drug strategy, which we're going to talk about, which has a number of different facets, and we've received some additional investment to support implementation of this strategy, particularly around recovery, treatment of people who have substance misuse issues. There is also a requirement, which is quite significant, for us to set up a new partnership locally called a Combating Drugs Partnership, to implement the national strategy, and there's some quite clear asks of each local area to come up with a responsible officer, a plan, and there's some new governance that we'll need to set up. So that's kind of why we're bringing this here today. I don't know if we've got Sarah back in the room. Should we just Sarah?
Let's just carry on.
Sarah, can you hear us?
Yes. Oh. I don't think she can.
Should we just keep going?
Let's keep going.
Keep going, Joe. Let's go on to the next. So I've talked about the background. So let's move on to the next slide. So, Joe, do you want to take this one?
Yeah, I was just going to say, so this slide just talks about the benefits. There are clear benefits in combating illegal drug use in Haringey. We all know about the parental drug use is a risk factor in 29% of all serious case reviews, as colleagues from Children's and other adult services will know. Heroin and crack addiction causes crime and disrupts community safety. A typical heroin user spends around £1,400 per month on drugs, which is 2 times the average mortgage, depending on where you live, of course. And the public value drug treatment because it makes their communities safer and reduces crime. 82% have said treatment's greatest benefit was improved community safety. Next slide, please. Okay, so this slide is pretty old, but I think it just gives a bit of a kind of an overview of the prevalence of drug use in Haringey specifically. And I'm not going to go through the whole slide, but you know, up until 2017, so this is a 7-year period. Haringey had higher rates of opiate and crack cocaine users, both than the London and national rate. And at that time, there were around 1,500 opiate users and around the same number of crack cocaine users. And obviously, these are individuals who not only have their own lives, but also impact on other people's lives in the borough. So treatment and prevalence of drug users in Haringey is a key priority for us. Next slide, please. I don't know if... Next slide, please. Okay, thank you. So this slide really talks about, it's a snapshot basically of drug stops or stop and search for drugs between 2020 and 2021. Now, on first glance to that, you might think, well, okay, we've cracked it then. So we're seeing massive reductions all across the board. I know that obviously Stroud Green is a bit of an outlier there, but you know, you're seeing, you know, 20% and 53% reductions. There is a caveat to this. And I know John Waterfield's on the call as well, but during the pandemic, the police saw a massive reduction in the use of stop and search simply because they were managing COVID compliance at that time. So this may slightly be misleading in terms of the levels that we expect to see in terms of drug stop and searches. John, I don't know if you want to say a bit more about that in terms of kind of where we are now in terms of those levels and what you're currently seeing.
Thank you. So yeah, I think I guess a lot of number of issues around that, and we all statistics try and explain certain things. I think we need to factor in a number of different issues over the last couple of years. So Black Lives Matter, George Floyd, I think focus on violence, and some of that probably hasn't been as much volume of stop and search drug issues, and obviously violence is our biggest focus around that, but obviously drugs is an enabler of violence. Potentially have a younger generation officers coming through around that, but again, it should be intelligence led. Again, we've got use of a body-worn camera around that, but the volume, as you can see, has dropped on the sort of stop and search thing. That will probably generate some of the more volumes or drug offences. That said, it'll come to the slide later in the slide. There is obviously drives against some of those drug lines coming into the borough and to try and cut them off, which do fuel many of the drugs offences and addictions.
Thank you, John. Next slide, please. Okay, so I'm not going to go through all of these slides. These are all in your pack, and we want to leave enough time for some good discussion around this.
Hi, I'm back, Joe. I can do
thank
this.
you,
I'm
Sarah.
sorry, everyone. It would be the moment my laptop collapsed. Really, the drug strategy is based on the Dame Carol Black review, Dame Carol Black was an independent review. She's very respected across government, so this is going to stick. And she found a number of things that we need to address. First of all, the massive disinvestment in substance misuse treatment, and she particularly highlighted that for young people's drug treatment. She talked about the workforce, the shortage of the workforce, the demoralisation of the workforce, and the high caseloads of the current substance misuse workforce. She talked about big gaps that we as a board can look at addressing in terms of health, mental health, housing and employment for those in recovery from substance misuse issues. She talked about the disconnect from crime and treatment. Suddenly we're justice and we're safeguarding and we're not a partnership anymore. And she highlighted that there has been a breakdown in co-delivery, in joined up in systems thinking, both at a national and a local level.
Next slide, please.
So the government responded to this with a 10-year drug strategy, which is called From Harm to Hope. So there's 3 elements of the drug strategy. They're things that we're going to recognise when we're looking at tackling drugs in the community. Breaking the supply chain, so making it less available. Delivering a world-class treatment system for those that need treatment, and reducing demand. And here there's a kind of focus on recreational drug use. We've been given a combating drugs outcome framework with measures which we are going to be expected to address. Next slide, please.
Okay, so one of the areas that Sarah's just mentioned is breaking the drug supply chains. I know we've got police colleagues on who can come in and speak more about this. But just wanted to highlight some of the key points in this slide. That obviously the UK is Europe's largest heroin market, which is worth about £6 billion a year in terms of illegal drug sales. The Ministry of Justice plans include, amongst other things, targeting that middle market that Sarah just mentioned, which is breaking the ability of gangs to supply drugs to wholesale to local neighbourhood dealers. Rolling up county lines, which is a massive issue for us nationally, not just in London. It's a national issue where young people are being exploited, and more importantly, bringing those perpetrators to justice and safeguarding and supporting those victims. And alongside that, hopefully we'll start to see a reduction in violence and homicide that's associated with illegal drug supply. Tackling the retail market so that police are better able to target local drug gangs and street dealing. And some of the actions, as you can see from the slide, is to close around 2,000 more county line distribution chains, disrupt around 6,500 organised criminal groups, recruit more police officers. Obviously, that will help, and then using technology really to develop, detection and kind of monitor trends, etc., to reduce that flow of drugs into prisons. Next slide, please.
So the second ambition is delivery of a world-class treatment system, and I'll talk about the local investment in a minute. But these are picking up the things that Dame Carol Black reviewed, so more treatment for young people, better integration with mental health, and more employment, more work with employment and housing providers, and then that linking up and making sure that everybody in the criminal justice system, whether it's leaving prison, whether it's on probation and being given a drug treatment requirement, should all have a place in treatment. Next slide, please. So the final ambition is a slightly more cloudy one for us, which is about tackling, and the government talks primarily about tackling cocaine, recreational cocaine use in the strategy. But what is clear is ambition 3 and 4 in this is that we need to increase the universal prevention programs for young people in schools, and we need to support young people and families most at risk of substance misuse, investing in a range of programs that provide early targeted support. So that's not necessarily just the treatment bit of this. This is about our children's workers being able to talk to children and young people about drugs, realistically about drugs and drug use. Next slide, please. Here's the context of the funding. So we already invest significantly, and it's very important that we don't disinvest any of this because it would impact the new grant. So the new supplementary grant is 795,000 this year, 1.3 million the year after, and 2.5. So as you can see, there is real money behind the treatment element of this. There's also separate money for inpatient detox, and here there's an issue about capacity and rebuilding the sector. So we probably will work as London with that pool of funding. Next slide, please. So with the money comes ambitions. So the national ambition is to increase by 20% adults in treatment. Haringey as a first wave is expected to reach 23% increase. We've set ourselves a target of increasing the number of treatment places for young people by 43%. That is actually realistic for us given where we were and the drop that we've had in recent years. Next slide, please. So we've got a plan. It's off and ready to go for this year. That was developed in some events done in May with co-producers. We have strategic co-producers and with staff and managers. And really the first year for us, there isn't the workforce out there to get a whole load more key workers. The year one for us is about building back, building stronger and building fairer. So we will have continue with our new criminal justice team. We've got peer-led projects, including the Bubik Night Outreach, which is going till 3 o'clock in the morning at the moment. We've got a co-produced new recovery project down at the Pavilion. But we're also investing in employment worker from Haringey Works, in the Federation coming in to do some primary care work, and connected communities coming in, and Homes for Haringey have just made us an offer for free to come in as well. So picking up the kind of cost of living crisis, the effects of COVID, poverty in our clients, and in that way supporting key workers to get on with the drugs work and other people to facilitate the other things in someone's recovery plan. But year two will be about workforce, and we are going to need to find a significant new workforce because obviously everywhere we'll be looking for new workers. Next slide, please.
Oh, over to me.
Joe.
Yeah, so I think we'll set this out at the outset, as did Sarah, around the need for commitment from partners at this group around how we're going to ensure that we not only succeed at trying to reduce some of the issues around drug misuse, but also that we meet the requirements of the strategy. I know Will's going to talk a little bit more about that after, but so as you can see there, as Sarah mentioned earlier, it's about services such as probation, screening and referring into treatment, supporting the increase in community orders, continuity of care within prison, for colleagues in housing, identifying housing options for those trying to recover. It's a kind of whole system public health approach that will require that real level of commitment from all partners at this meeting and further afield. Next slide, please.
So I think this is over to me. So I'm going to talk a little bit about some requirements that we have around governance for this. So not only is this really important for our population, and actually there is something around sort of vulnerability of some of the residents that we're talking about here, as well as the harms, but it is also now there's a joint combating drugs unit that covers a wide range of government departments, and each area is being asked to set up an infrastructure to support delivery of the national drugs strategy. So there's some things that we have to do quite quickly in terms of setting up this governance, and it will require partnership from all of the organisations around this table. I think there's a really strong role for the police in this, because you've seen the outcomes. There's some specific outcomes around kind of disruption of drug supply lines as well. But what we have to do in the next few months is set out on the left-hand side of the slide. So we have to nominate our senior responsible officer for the patch, there is some opportunities, potential to work across boroughs as a partnership, but in conversation with other North Central London boroughs, and due to just the complexity of working cross-borough political challenges, we're very much focused on doing this on a Haringey basis, so we hope we get your support for that. Once we've agreed who our senior responsible officer is, we have to form our combating drugs partnership. That will be a relatively senior level group that will feed into the Community Safety Partnership and Health and Wellbeing Board. And then we have to get on with the work. So although we've started on the treatment aspects of the programme, this needs to look across partners, and we need to do concise and proportionate needs assessment, a delivery plan, and then set up that infrastructure in terms of reporting. I think earlier in the pack, we had some of the key indicators that we'll be asked to report on. So just to let you know where we are at the moment on this. So because of the timescales and because of that, really strong focus on treatment and recovery, and that sitting within the kind of public health budget, our initial recommendation is that the senior responsible officer is myself as Director of Public Health, but this is about partnership. So it requires we require really strong leadership and a sort of name leader from the police and other key partners as well. So that's one of the things. It'd be good to get kind of police input today around that. And then we need to make a submission in the next few weeks saying this is what our plan is. This is who will be. This is how we're going to sort out our governance. I think we're quite well placed in coming to this board quite early. We really have not had this guidance for a long time, and it's been moving quite quickly. So in terms of the discussion, I think clearly there's a lot that we've laid out here. So any questions about and contributions around the issue itself, but then we also need to come back to some agreement to take this forward so that me and my team have got a mandate to bring partners together to form this combating drugs partnership. So I don't know if is there another slide?
I think there's one more, Will.
One more on governance. Yeah. So this kind of just shows the local links and then how this will report into government as well. So really showing the links between this combating drugs partnership and some of the other existing groups that we've got. We do want to keep this as simple as possible because we know there's already quite a lot of complexity with different governance and different meetings that people attend, but there is a clear requirement for us to set up a specific partnership group on this. So yeah, I think I'm going to end there, and we'll go back to the discussion points as I suggested, Chair.
Thanks, Will. That's really helpful. Do you want to? I've got a question just about before we move on to those. It might be for you, Sarah, and for Joe, really, about how this connects in with how the London dimension fits in. Is there any clarity on how the London dimension fits with our own board and what we might do at London level versus what might happen here locally? I'm particularly thinking about some workforce issues.
Sarah?
Yes, so what I'll do, yes, workforce. So OHID has a national, London and a London level, and both national and London are looking at a workforce strategy. We need to broaden our workforce, but yes, we've still got a battle. I think locally we need to get on with this, and we have. So we've started to talk to HALS about all those lovely residents that are doing ESOL courses that could come in and be volunteers, and then by next year we actually paid for, with last year's money, 5 of our service users who are in recovery to actually do a diploma in health and social care with the drug agency within. So I think we need to build. Along with, there is very similar. Cassie's coming in here, but there's some very similar roles in the federation as well around navigators. Thank you. Thanks very much. I think that's really useful. I think it deeply connects with some of the conversations we're having at Health and Wellbeing Board, doesn't it? I'm going to bring, the order I've got is Beverly, and then I'll bring Cassie and Mike in. So Beverly.
Thanks very much, Councillor Gisnes, and thanks Will, Sarah and Ben for really excellent presentation. It's the investment is really well welcomed. So just 3 points, and I think the first point is probably because I'm fresh from a transitional safeguarding conference this morning. I noticed, Sarah, you were also there. And just really, just to ask the question around, would it be useful for that sort of concept of transitional safeguarding to fit with, and basically where we're looking at vulnerabilities of people who could be from age 14 up to 30. So not an eligibility approach, but a vulnerability approach, whether there's room for a particular emphasis on that sort of group. And I think what we discussed earlier was really around how we can work in partnership and take support for those vulnerable young people as a priority. The second comment is really around workforce. And I think you've mentioned it just now, Sarah, in terms of your approach to support people with lived experience, you know, the diplomas, etc. I think really welcome that. It has to be a real central focus of our sort of workforce strategy going forward. And, you know, just listening to the young people this morning at the Transitional Safeguarding Conference, it was so inspiring to hear their voices and, you know, in terms of the work we can do together. And I suppose the third point is just around equalities. And I didn't really see it shine out in the slides around our approach to the inequalities within the system in terms of drug take-up. We know all the links to the mental health, you know, people with mental health needs, social deprivation, etc., etc. So I just wondered how we could sort of support you in sort of bringing that out a little bit more. But those are my points. Thanks very much.
So yes, the transitional is always on our minds. Our services go up to 23 in a young adult service. And Eduardo and I have worked together on one of the new posts that we're creating is a vulnerable young adults post that in terms of a care leaver will work up to 25, elsewhere it'll work up to 22. And actually one of our criminal justice workers, so when Joe and Shirley's predecessor and I were planning for the criminal justice team, we also wanted a young males worker who would work specifically with that group. I suppose the other thing I didn't say from the workforce is that we do need the top tier as well. So we need to attract social workers in, and we need to get into social worker education and tell them, great, you know, jobs is a great place to work. In terms of equity, we do fill out on all protected characteristics as a data sharing set, and we look at those every single monitoring meeting. We look and we have themes. And we also have specialist services. So BUBIC was set up because there was a huge gap for young male crack users in Haringey, and BUBIC was set up. We have a Polish worker who's been with us for a very long time, Beverly, you'll remember. And that was from a piece of work about street population and who they are. We've just looked at our rough sleepers data, and it's women that are dropping out, which won't be a surprise to lots of us. So we've got a women's group, but we need to shore that up and do more work. So we're always looking at it. All of the protective characteristics come into our life. I think, you know, disability, we're looking at learning disabilities and what our information is and how we give it.
Thanks very much, Sarah. That's really helpful. Thanks.
Excellent. Cassie.
Thank you. And again, yes, really exciting to hear about this work and to think about that expansion, and additional investment is always an exciting thing when it's coming into Haringey. I guess I was thinking about the partnership approach, which I completely agree is absolutely critical, and the strategic partnership body that Will was talking about. And I guess I was thinking about the NHS contribution, and actually how every part of the NHS touches in on this, whether it's the acutes, whether it's community services, our mental health trust, obviously primary care, and just wondering, I guess, how we make sure that the strategy and the approach is really taken on board by all of those groups, and slightly aware that that isn't an easy fix. It never is. Partnership is never straightforward. And for example, just having someone from the ICB might not give us that real buy-in and cross-culture. I guess I was wondering, what are the opportunities via the Borough Partnership and the Live Well Board? And this might very much be at the centre of Live Well, but I think it's really critical that we make sure that that's embraced, but also just making sure where you have representation on a board like this body, or that we are really making sure that that partnership lives. And I guess it's not just us. I guess it's where other groups connect in. And I was thinking about the COVID response, and we've often talked about how we were able to partner, and of course it was also because there was quite a lot of money, but we had that partnership approach, I think, led to much better outcomes. And I guess it's that criticalness of how we find a way of doing that. I don't know if that's a question or a comment, but that was my thoughts.
Well, I share your point actually, Cassie, because the challenge is that ICB it's very broad. It will be very broad and not necessarily carry that local flavour. But the challenge is also that we'll want to make sure that there's awareness and understanding at the ICB level about, excuse me, about what we're doing locally and how that affects our priorities and etc. I don't know, Will, if you have any or anyone else wants to come in on that. Or maybe it's something to reserve and take away. Okay.
I think the same. Oh, so I was going to say, Chair, I think the same is true of the continuity of care part of the strategy as well, because we know that often care pathways break down when people go into prison, for example, and come out of prison. These sorts of things have always been an issue in terms of that, keeping that capacity, I suppose, within the system. So I think these are some of the things that we'll probably have to go away and think about as a strategic team, just to make sure we've got a local picture as well as that kind of taking care of the national kind of strategy, but making sure we keep it as local as we can, which I think explains Will's point about whether we do it joint borough or single borough, etc., etc. So I think that lends itself to that argument, really.
Before I bring in Mike, does anyone else want to speak on this particular point that Cassie's just made, in case we're not moving around? Okay.
It was just me, really. Just wanted to come back in. So I totally agree with Cassie. This has to be kept live with the Live Well board, absolutely. But I think there's something around the connection between the ICP, i.e. our borough partnership, and the NCL sort of ICB, because there is just something around how we can develop the flow of partnership working upwards as well as across the system. And I think that's really something we need to take away and probably think about, how we can have that influencing on what happens at the ICB level as well as what happens at place. Thanks.
Thanks, Beverly. Mike.
Thanks, Lucia. And obviously it's welcome that there is this sort of efforts are being made at central government level and funding's being given, and that there's this focus on treatment. I think that's fantastic. I have two questions. One of them is, I come from a position that, decriminalisation is actually the best way forward. And part of that is actually because if you are, if there's that threat of punishment is likely to divert people away from seeking treatment, right? So actually, if you want to have an inclusive treatment environment, you need to people need to feel safe that they can go there and they're not going to be punished. So on that question, it's about the partnership between police and these services. In the pack, it talks about police and it has diversion, and I guess diversion is a kind of de facto decriminalisation if it's done right. And I just wondered what is being put in place to ensure that communication at the highest levels of the regional police force and the services in terms of treatment are working together, so that message is put through. So there's that number one, and number two is just about funding. And as far as I can tell, based the funding, additional funding Haringey will get is around 2 million. Now, I can remember, I think we can all remember when 2 million was a lot of money. But the question is it now, you know, in terms of the ambitions that we have, does that feel like it's going to satisfy those ambitions and be something that is actually a sustainable program at that price, at that cost? Thanks.
Good questions.
Sarah.
I can do the last one and not do the decriminalisation one. Or I'll talk about the partnerships. So Joe and I have been hanging on to a very old system of diversion, and Shirley, I can see Shirley wants to come in from probation. The three of us are very passionate about diverting people into treatment. It's the teachable moment. It's the opportunity to do harm reduction, if nothing more. So we're very keen, and the police locally have kept that system going. So they have been doing test on arrest when they weren't really mandated to have to do it anymore. So the pieces of the system are there, and I think, yeah, there is an intention both locally at the London and the national level to push that back so that people are getting alternatives to custody, because short custodial sentences are just rubbish. And you all know they're all rubbish. They're disproportionate. They're rubbish. We need people diverted into treatment. Is the money enough? We haven't had any money for 15 years. We've had less and less money. I have a concern about alcohol, of course, because this focuses, although it says drugs and alcohol, it's all about drugs again. But yeah, it's welcome. The money is welcome.
And I think it's fair to say, isn't it, Sarah, that we're in quite a good position in Haringo to take this forward because of where our services are at, because of some of the partnership that you're talking about. And that's a strength, and having a bit of inward investment builds on that, whereas perhaps in other local authorities not quite in the same place, are they? And that's a concern about alcohol, because you raised that with me before, which is that we don't want to lose that strength that we have, because it's very important for our residents. Thank you. Do we want to talk a little bit more about, Shirley had a hand up, and did you put your hand down? Do you want to come in, Shirley?
Yeah, please. Just a couple of points, really. Just in response to the councillor's opinion on decriminalisation, because I think that the enforcement side of the criminal justice side of drug treatment, for some, is what actually makes the drug treatment a success. So often we find that, well, we know, don't we, when we've got a habit that we think is serving us well, we don't always want to give that habit up. And sometimes going through the criminal justice system and then being held to account for when you lose your motivation and you don't fancy going to the drug services, often when there's a consequence for not staying engaged, that is really helpful to motivate people, because changing an addiction is really hard. And if it wasn't, we wouldn't have a problem. We wouldn't be sitting here discussing this. So I think it's just making sure that the teeth side of the drug treatment is useful and motivating rather than purely punishing. And I've done shed loads of work with custody sergeants where we've moved them from seeing drug treatment as an enforcement tool rather than a soft touch of dealing with drug users. So I just think it's just about making sure that narrative is there, that enforcement doesn't necessarily mean punitive. It's a way of supporting people when the going gets tough and they want to just fall off the wagon a wee bit.
Thank you. That's a really helpful contribution. As we were talking about police, Will had raised a very specific question about the engagement and the formalising of that. Is that something that you want to cover in this meeting, or is it something that you want everyone to take away, Will?
So it'd be good to get a police view today, but they may not be able to answer that, so we might have to just take it away. But if anyone from the police feels that they can kind of come in on that, who would be the right person to be that key point of contact at a senior level?
I will. It's Seb speaking. So I'm here principally to support Joe in terms of the DA input. So I'm not in a position to talk wider around the drug strategy and the police intervention in relation to that. The right person would be Marco Bardetti. So he's the detective superintendent for local investigations. My only insight is we also have a violence plan. So drugs we know is a driver for violence. So for me, it's how you ensure that the two plans don't duplicate each other and deconflict, because one influences the other. So that'd be my only insight into the work around the drug strategy.
Okay, I think that's really helpful actually. So that's something for us to take away. It sounds like, Joe, probably for you and your team. So going back to my list here, Susan.
Sorry, Councillor. Oh, sorry. Apologies.
Oh no, sorry, Shirley, come in.
Oh, you know, I was just going to say in response to the officer, I wonder if there's also an overlap with IOM, and I wonder if we may need to think about that as well, because all the relevant partners are around that table as well.
Shirley, do you want to tell us what IOM is, us non-experts?
Oh, sorry, I apologise. That's Integrated Offender Management. So that is those offenders that are causing the most chaos, not necessarily the most harm, but they are the people that are always at the housing, kicking off at the benefits office, you know, the people that really take up local resources, cause a lot of local nuisance, the shoplifters, those types of service users. Partners invest in an IOM approach. So we invest to work with the people jointly, and that way we sort of invest more and then save, you know, because we turn people around and then we prevent them coming back and back and back to our services. But it really does fit in with the revolving door service users around drug use.
So, Shirley, I was just going to add to that as well, just to pick up on Seb's point, that also will include, Seb, offenders who have been convicted of violent offences, as well as domestic violence offences as well. So some of those hidden harm issues that we talked about earlier, hopefully we can start to tease them out through some of those interventions through the IOM as well. So it will fit nicely with that.
And also there is the, I don't know if it's called the youth IOM, but it's the IOM for youngsters. So it's about really getting in there early, doing some of that preventative stuff to stop these youngsters becoming adult IOM offenders.
Thank you. Thanks very much. That's very helpful. Susan.
I just wanted to pick on your point, Councillor Dasneves, around, you know, what's been done at the local level and what's been done at the London level. Because in the slide that Sarah shared on the investment, there is that second very small pot of money. I mean, it's less than 60k each year for the inpatient detox grant, and that's what will be pushing to have a London-wide response to that, because locally 60 grand, you know, doesn't go far. It's better that we have a collective London approach for that, and we have a lead director of public health in the London Association who leads on drugs and alcohol, and myself and Sarah will be pushing to make sure that we get best use from the other local authorities of their inpatient detox grant to put with ours, so that we can make sure that there's a good response for that particular inpatient service that would be required. And then we would make sure with the pathways that the, you know, the right Haringey residents gain access to that particular service.
Thanks, Susan. That's really helpful. Yes, and you did remind me. I saw that and I did want to come back on that. So we covered two bits there. That's really helpful, because that really is very important, isn't it, for some people who've had a few goes, well, more than a few sometimes, haven't they? And it hasn't, and they really need to be in, don't they, for that period of time. So it's making sure we've got more of those kinds of places. Yes, well, I think that's interesting. Making sure that everybody pulls their weight, I think. Really important. Beverly. Yes, it's you, Beverly H.
Yeah, I'm just waiting for my mic's a bit slow this morning. Can you all hear me? Sarah, really, and Joe, really helpful presentation. Fired off a number of neurons around our thinking. Sarah, can I get some time with you, perhaps outside of here? the issues that I think we need to explore further. I really appreciate the offer going up to 25 for our care leavers. What we're finding is that is still a cliff edge. And when I do the analysis on our data, what we're finding from 26 to 28 is when the vulnerability is most acute. And if there was any possibility of starting later to get a further extension, because that's when they start to trickle back into adult services and to drug and alcohol services, but by then they are less likely to engage. So I'd really like to talk to you about when we start working with our care leavers so they can get, after the PA's roles ended, we have some concentration of intervention after that. The point around qualified social worker is a huge issue. So I'll just mark it here, but we need a longer conversation outside of here about how we engage and tap into that part of the workforce. But I really wanted to just plant a seed. Nick is not in with us. I think the earlier we start with parents and working with parents around substance misuse, the better. And I'm wondering whether we ought to have a conversation around early years, children's centres, and whether those programmes are really helping our parents to be confident about having those conversations with their children, because I think we need some intimacy here around people who are responsible for primary care and for guidance beyond 26, 30, 40, 50 potentially. And my other query is, we have some concerns about care leavers and children who are in semi-independence outside of the borough. And again, an analysis of the data, and Sarah, I know you're familiar with this, is that those are the most vulnerable children, on how this programme is going to be able to reach beyond the boundaries of Haringey to make sure those children don't fall, because they're not just falling between our gaps, but they're falling in the gaps of other local authorities and the ordinary residents ping-ponging between boroughs. So outside of here, welcome a half-hour discussion with you on those 4 points, please.
Thanks, Beverly. They're really good points you raise, and you just sparked my neurons as well. As a parent of a child in the primary school, I was thinking about all these really much better quality conversations we have now with children, and as part of PSHE around all sorts of things, including domestic abuse, etc. But if I think about it, what's the role for conversations about drug and addiction in an age appropriate way? I'm asking that question because I'm thinking that that just thinking about those early conversations. We
got the SHUI data back, haven't we, Susan? Which we presented this to Children's DMT last week or so. And actually in Haringey, the schools are talking, but this was at secondary, the schools are talking more about substances, but very little is coming through the parents. So I think Baby's really right about thinking about the parents and equipping them rather than just us going in and talking to the children in school.
Okay. All right.
Yeah,
well, I'm throwing it out. I'm throwing primary out there as well, because I don't know how. Hopefully, no one's shocked by that here. But I think it's interesting. More in that context of knowing yourself and in that development of individuals and people and understanding themselves as human beings.
Yeah, and I think we can incorporate this into our Healthy Schools programme and work with the PSHE coordinators and the Healthy Schools leads, because our provider insight platform, the Young People Service, do go into schools and deliver education. But I think there's additional work that we can do, as you say, to also reach the parents as well through the schools. So certainly I think we'll be looking into that and using the data that we got from the survey that we do every 2 years that Sarah mentioned around, health related behaviours. So there's lots of hooks that we can use to do further work in schools, definitely.
Chair, I was just going to say, and especially with the younger age groups, I think there's there's a real need to kind of widen this out to new drugs, so things like NOS, lean, and other designer drugs that are coming onto the market, which are particularly attractive to young people. Because I envisage in years to come, they will be the drugs that we'll be talking about. Some of these that are currently on the market and can be obtained on the dark web and other places. So yeah, just thank you. That's a really, really good point.
Yeah, and even that some of the things that's being raised to me in a sort of minor way. Well, I mean, it might seem more minor to us because of the things we're talking about here, that are kind of higher end of opiates. But a lot of families now talking about nicotine use, and and bubblegum flavors and what have you, and just about those kinds of informed, something that seems very much like sweets for children, quite, and that it's that transition. There's talk of quite early use of it and sort of implications of that, etc.
And Beth and I are having conversations about, and we've just done a survey out to all the social workers, asking what conversations are you having with young people about drugs at the moment? Is it dangerous, don't do it, or are you giving them a bit of harm reduction? What's comfortable? What as corporate parents should we be telling young people about drugs? Because it's not just that's lean, that's that. What we need, it's an anchor, isn't it? It's resilience. It's why you don't want to use these, what harms they could cause you if you are. How do you do that responsibly?
Yeah, and much like internet safety, us parents need help. On ourselves, but also on that having the right conversations in the right kind of way, and the tools and the knowledge. Beverly.
Is that me?
Yes.
Thank you. I also think that there is a role for our primary care. I'm really impressed by the work that people like David Marsden and others are leading in terms of the MDT cluster approach, starting to adopt some of the principles of the early help panel, talking about children before they are referred to early help or to children's social care. Our analysis of the Your Choice cohort of children shows that many of them haven't seen a GP in 5, 6, 7 years. And these are children at home with their parents, and some of them sadly are using cannabis to manage anxiety. But you had the connection to take them to their GPs to see whether we could explore social prescription and what other advice could be provided to the parent seems to have been missed. So I think there is an opportunity for us to really work with our GPs through the new MDT approach as well.
Thank you. That sounds very good. That's very helpful. Thank you. I'm going to move on to Jeffrey and Mal, and then Hubert, and then we might have to move on because we've still got quite a lot on the agenda. Jeffrey.
Thanks, Chair. Thanks. So I was about to call you Chris. So thank you, Sarah, and Joe as well. Okay, and I can see why you brought it here because it really fits within the two boards. My question really is just kind of two parts to it. The first one is there's a slide that talks about initial plans for this current year. So it kind of, for me, is we've got a 10-year strategy to what I can translate into like an annual plan, for example. So what are we going to be doing in terms of, because at the moment, all you've got is a plan for 1 year, if that's correct. So how will we develop and indeed co-produce the plans subsequently beyond this first year? So some idea how that might be done, and there's already been discussion around, bringing the, the NHS and so forth. I would also suggest the VCS, you've mentioned BUBIC, for example. I know there are others as well. So what's the process around, that? Because at the moment, the current one has been produced by staff and service users. I don't know, staff from where? Is that from the council only, or is it?
No. That's everyone involved in substance misuse. So BUBIC is Spirited. So I'm just talking about the world-class treatment. Don't forget, there are two other strands to the strategy, and we've actually only had to do 1 year plan for the world-class treatment bit. So I think that's what Will was alluding to in terms of the combating drugs partnership, is that we're going to be expected to have a plan.
So is my question relevant or not then, Sarah, about annual plans going forward beyond the 1 year?
So world-class treatment, yes, we'll be co-producing our plans for world-class treatment. We've only got 3 years funding, not 10,
right?
Unfortunately, but yes, so we'll be continuing to work on the world-class treatment elements. And then we already have, so what we have at the moment is we have a criminal justice treatment steering group where Shirley and Joe and other partners sit, where we talk about the pathways, the continuity of care between criminal justice and treatment.
Thank you. Hubert.
Chair. Thank you, Joe, Will and Sarah. A quick question for me is, have you considered the links between this strategy and our young people at risk strategy? So I'm thinking about, our young kids getting drawn into this through exploitation, and we know that trajectory often leads to serious use violence, as Seb mentioned. So I was wondering, have you considered those interventions, and it would be good for one to feed into the other?
Can I, oh, sorry, Sarah, do you want to come in?
Yes, Hubert. So we've been to Children's DMT as well, because although they include young people, this is so much about adults, really. So I do think that the young people bit of the strategies needs to sit in the young people's world with the youth at risk, and that we have a plan that links to BEVs and youth at risk and other strategies. But that's still to kind of be explored. Because I don't think it should sit with the drug strategy, otherwise the young people will get lost.
Yeah, so maybe it's a conversation offline, Sarah. That's not a problem. Yeah, I can totally see that. So that's a conversation with us and our children's colleagues. That's fine. Thank you.
Thanks both. And I'm going to take Zena, and then we're going to wrap up this part. And unless Sarah and Joe and Will might want to come in with some final remarks. Zena.
Thanks, Lucia. Yeah. It's been a very interesting discussion. I haven't heard anything about the implications about where people live and what happens. Substance abusers are often very difficult people to live near for obvious reasons, but also they're very difficult. I imagine it's difficult to get housing for people. I just want to follow on, put that in a bit of context. I was at the conference this morning on transitional safeguarding, and I was talking to one of our care leavers who was a presenter at the conference. Fantastic, articulate, bright, done really well. Said he lived in Tottenham and needed to move because it was so scary living in Tottenham. Lives probably 10 minutes, 15 minutes down the road from me. But when he told me the road, I could see exactly why he felt that. And of an area where there's a huge amount of drug dealing going on the street corners in North Tottenham. And so my question really is, we can do all this, but if people are living in an area and they're housed in an area, maybe they've come out of prison, or we're avoiding prison or care, and the housing placements are in areas where we know there is a high incidence of dealing, and it is both it's in your, it's there, and you could be introduced, you could be drawn into it all, even if you're doing your level best. How in this plan have we got an idea of how we're dealing with that? Because when young people leave care, we're required to house them. So there's a group of young people who we want to keep supporting, as Bev has said, the two Beverleys, and people who are drug users themselves, who probably got nowhere to go. So the whole housing thing, and I personally, and since we're all revealing our views, I'm not very much in favour of congregating large numbers of people together who have very serious problems. I don't think, unless you're very well managed, that can cause serious social problems in the community. That's not being NIMBY, it's just, I think we have to think hard about how people are accommodated. So that's sort of not half a question and some opinion.
Yeah, so Beverly might want to come in here about housing, but I met with, so place is very much on my mind in two ways. First of all, about residents and antisocial behaviour. And I think with our new investment that we had last year, which we've invested in Bubik and some time so that I can actually go to tasking and partnership meetings, I think we're starting to make a real impact in terms of getting to hotspots really quickly with Bubik, talking to who's there, finding out who's there, seeing if there's something we can do with them, and then feeding back to enforcement to say there's nothing we can do here, it needs something that's enforcement. Just say Joe's nodding at me, and having Bubik till 3 a.m. in the morning out there is really helping. But yesterday, yeah, I caught Denise Gandy and I said, oh, combating partnership boards, it's coming back. And in my mind, we'd absolutely have to have housing on there. Okay. And she said, absolutely. And then she gave me a housing worker to come into the drugs service next week. So I think that the intention to engage is there. Beverly's nodding, yeah.
Yeah. If I could just briefly, I know you want to move on, Councillor Desnes, just in response to Councillor Brabazon, totally wholeheartedly agree with you around, you know, how we place people with significant issues together and then the challenges that present. And I've already had conversations with Denise around a relook at our allocations policy. So it's on our radar. Thank you.
Thank you. There is a whole piece of work taking place, isn't there, around alongside that work of having brought Councillor Haringo back from arm's length. So I know there's a lot of work and a lot of good brains thinking about how that might look in the future. So thank you. Okay, Will and Sarah and Joe, thank you. Are there any sort of any things that we haven't really covered off, or anything that you're going to go away and pick up some good conversations that are going to take place, it sounds like, outside of this sphere? Is there anything else you want to say before we move on?
No, thank you.
No, thank you very much, and thanks to the team, because I know it's an important piece of work, and as I said, we're starting from some good foundations, so that's a really positive place to be in making the best use of the funds that we've been given. So thank you. Moving onwards, we're now on to our presentation on violence against women and girls, and Chantel's going to lead this item. So
Hi.
Go ahead.
Thank you. I think Dominic's going to kindly share the slides for me. Thank you. So I'm Chantel Fatania, consultant in public health. And this is just to provide a bit of an update on VAUG. So obviously VAUG continues to be a high priority and high profile issue in Haringey, and yet one which we know is actually significantly underreported and remains largely hidden. You may recall that we previously provided a detailed update about the VAUG work at the December meeting, but we just wanted to update the board members on some of the more recent developments. So since the last meeting, the public health team and VAUG partners have continued to progress the work in line with the principles and objectives outlined in our Haringey 10-year VAUG strategy. From April 2021 to March 2022, a pilot project was delivered across Haringey to try and deliver a coordinated community response to VAUG, using an evidence-based approach to engage with our communities. So during that period, staff from 32 venues across Haringey were trained to be able to enable the venues to be what we call safe spaces, where victims of VAUG could speak to someone and be signposted to specialised services. So the venues that we have that are safe spaces included places like libraries, children's centres, places of worship, food banks, as well as advice and support services like Mind in Haringey, Connected Communities, the Citizens Advice Bureau, HALS and others. In addition, 150 VAUG community champions were trained to be able to link women and girls experiencing abuse to specialist services to increase their chances of being safe from violence. An evaluation of this pilot has been produced, and it will be available either at the end of this month or early August, and we can share that with board members. And early findings seem very promising. In addition to that, we have established a VORG business group, which was set up to strengthen the response to VORG across key agencies and try and tackle structural issues within the VORG partnership. As part of that work, an action plan was co-developed with the North Area BCU, which highlighted some strengths, but also some gaps. And subsequently, the North Area BCU have set up a specialist domestic abuse unit called ADAPT, and that stands for Advancing Domestic Abuse Prevention Team, and that's to support with prevention and earlier intervention. And there are 7 dedicated staff members, and this is a unique intervention developed specifically for Haringey and Enfield, and it's extremely positive for both boroughs. I think we've needed this for a long time, and it's a permanent team within the North Area BCU, so I think that's a really positive development. We also recognise that comms is really important. So we've been working on a 3-year VORG comms strategy, and this is going to be a multi-year scaled campaign, which really tries to aim to create a culture where VORG is not tolerated by delivering clear and consistent messaging about unacceptable attitudes, behaviours, and different themes like power and control, gender inequality, and what constitutes a healthy and unhealthy relationship, as well as information about local support services. So a draft comms plan was taken to the VORG Strategic Board, and we've had some feedback, and so we're going to revise it, but it kind of detailed things like the planned activity, some of the intended outcomes, how co-production would be undertaken, and how the comms would be disseminated for 3 years for each of the target groups, which are survivors, professionals, and communities. There's also been a number of training activities which have been undertaken over the past few months. So Humankind delivered training to all Haringey drug and alcohol teams on early identification of domestic abuse. We also commissioned DVIP to deliver 6 sessions which were intensive on developing skills in holding perpetrators to account. And we've also partnered with the North London Rape Crisis to deliver 4 training sessions about sexual violence, and over 50 people have been trained, and also Tender to deliver multiple sessions on the impact of domestic abuse on young people, and we've had over 100 people trained on that. Next slide, please. Prevention and early intervention is a really core component of the VORG strategy. We have worked on developing 3 videos by and for Haringey's young people, and there's a link to those videos there. And they really focus on challenging the prevalence of victim blaming around sexual abuse and other forms of VORG. And young people helped and design these films over the course of 13 co-production sessions. And they've been really well received. We've also been working with Solace Women's Aid to deliver training to key staff from all secondary schools by March 2023. And that's really to try and embed a whole school approach to preventing sexual violence, recognising that it's really important that messages are delivered at an early age. So the first training session will focus on improving knowledge of how to identify and respond to sexual violence, and the second session focuses on how to embed cultural change in education and young people settings to prevent rape culture. Our VORG coordinator has also co-developed the public health approach to supporting schools in preventing peer-on-peer abuse, and that's in partnership with the Healthy Schools Programme, Sexual Health, and the Anchor project teams. And so this has resulted in a summary of support available to schools through commissioned and partner services. We've also continued to commission the Protect Our Women project, which is an educational training programme about preventing VORG, which is delivered in schools to support young people, staff and parents around healthy relationships. And the Power Worker has trained 65 staff members across 7 secondary schools and colleges, and also delivered whole school assemblies to over 250 pupils, and delivered regular workshops and training about VORG to a further 200 young people. So, you know, a good amount of training there. Next slide, please. In terms of our commissioned VORG services, additional investment is going to be put into our Haringo VORG services because we've managed to secure some additional funding. Our service improvements are going to be aligned with feedback that we've had from our communities, frontline services, and women who have been directly impacted by abuse. Last year, we held a forum with representatives from BAME, our communities, and this highlighted some significant gaps as a result. And as a result, we've now commissioned a specialist service. So essentially, we heard the feedback and we listened. We've commissioned Imiche to provide domestic abuse service for women from minoritized communities, and the service provides crisis intervention support to women experiencing all forms of VORG and harmful practices at all levels of risk. So this is a new and exciting service, and it aims to provide specialist support which is holistic. Advice can be provided around accommodation, refuge, emotional support and counselling, advice around welfare and benefits. There is language support, and thorough risk assessment and safety planning, as well as signposting to other services and professionals, and supporting those with no recourse to public funds, immigration and legal matters. We are also commissioning an independent domestic violence advocate to support LGBTQ people who are at risk or have experienced abuse, and that will start imminently, and this is going to be provided by a specialist organisation called Gallup, who runs services in London as well as outside of London. And the organisation is person-centred, empowerment-based and trauma-informed, and their focus is on helping their clients decide what's best for them and then supporting them through their journey. We're also in the process of recommissioning our core domestic advocacy service. So our new IDVA service will advocate on all issues of domestic abuse, including legal, financial, economic, coercive control, housing, things like immigration, forced marriage, and try and address the more complex needs and multiple disadvantage and the intersectional needs. We know that, for example, that many women and girls are experiencing domestic abuse, but also may be struggling with mental health, economic hardship, substance misuse, and unstable housing. And so we really want to ensure a holistic approach to care where victim survivors aren't having to constantly repeat their story. So the new services will have expanded capacity and meet a wider range of needs. The new service model will also have a focus on supporting older women who are disabled, and those who are experiencing multiple disadvantage. And we'll also have links to smaller specialist services and sub-regional support as and when it's needed. And we're aiming to have the recommissioned service in place by June 2023. Our new service model is going to be based on previous feedback that we've had from community organisations, members, community groups and frontline service providers. But we're also really keen to hear from residents. So we're going to be doing further engagement work with our communities and frontline providers on specific aspects of the new model to guide the future service specification. We'll be running quite an extensive consultation in September and also have some focus groups with specific groups in August. And if there are any groups that you think we should be engaging with, then please feel free to let us know and we'll do our absolute best to try and engage with them. We will also commission a specialist domestic violence advocate who's going to be working with children and young people under the age of 18. We know this is really important because all the research shows that children experiencing domestic abuse can be affected negatively in many ways, such as their mental health and emotional problems, school attendance and achievement, and it can really have detrimental impacts in later life too, so early intervention and proper support is really needed. We already have a wraparound support for women in refuges, and that's currently being provided by Solace, and this contract will be extended until February 2025. And we are also going to be investing in a model to target behaviour change in domestic abuse perpetrators. to try and reduce the abuse and increase the safety of women and children. We're finalising the scoping of different options that have been effective in other areas, and we will soon have a preferred option to take forward and commission. And we'll be working closely with key partners such as the police and probation service. And further information is available about BORG and the services that we have on our council webpage. I think, and I just want to take this opportunity to thank all the partners that have been involved in this work, you know, because it just wouldn't be happening without a good partnership approach. Thank you, and I'm happy to take any questions.
Thanks, Chantal, and thanks to the whole team for, you know, there's a lot of important work there, and for what is a really big priority, as you say, for the council. I had quite a narrow focus question on one bit of the thing of the work that you presented, which was around the training of staff in the whole school approach and how that connects in with also community and parents. We were talking about parents earlier, so and it might be something that
yeah, so Bridie's been leading on that, but I'm wondering whether Manju, who's on the call, might be able to comment on that.
Yeah, fine. But just to say, so the commission that we currently have, Councillor Desnes, is the Protect Our Women, works with parents, teachers and the students. So we'll be holding some roundtable around that model that we currently have. We will be recommissioning that model, but we are hoping to include parents, teachers and students in that dialogue going forward. So there's support all around.
Thank you. Thanks. Beverly H.
Hi, can you hear me? No?
Yeah.
Yeah.
Oh, you can? I'm still showing as mute on my system. Have I gone quiet again?
No, you're fine.
Okay, good. Chantal, I've really enjoyed listening to the range of developments. Fantastic piece of work and much needed for us. Again, I'm happy to talk in more detail outside of the meeting, but when we did some work following some audits we completed around the children, some of the factors that have causing children to come into care, conversations with the courts, youth justice and family courts. The advocacy and support to the parent is much needed, but wanted to know if we could have a conversation around how we build in some into the programs parental understanding of the impact of domestic abuse. When I look at all the children that are open to us for serious youth crime, when I look at the reasons for some of the violence against the Everyone Invited program that we're running through schools, all of those children have one thing in common: they've all witnessed or experienced domestic abuse in their home. And I think that we are doing a lot of work, rightly so, to advocate, to support the women particularly, but I'm not sure that that's trickled into our parenting programs. So I'd really welcome a conversation to unpick that, share the findings with you of our audits to see whether we could build that into the parenting programs with our colleagues from Early Help, and how we particularly ensure that our parental knowledge of the impact of domestic abuse outside of statutory work is more widespread. And I'm looking at the data for the children in school and the children who we're most worried about, and there's a kind of a disparity and a mismatch there. So I'd really welcome a more detailed conversation around those issues.
Yeah, happy to discuss that, Beverly, and I think Manju wants to come in as well.
Yeah, just to add, Beverly, so historically we used to have this program called the Parallel Program. So it's about working with the children, working with the parents and the mothers primarily, so for them to understand the impact that's having on their child, especially if they minimise the DA. So what we've recently secured this year was an additional worker for our refugees. So we work with Triborough, we work with Islington, Enfield and ourselves, and we've got Solace as our main provider, and then we also have the London Black Women's Project. we have secured a worker to go into all those refuges to work with those women and children to address everything you've just mentioned, so that they understand, and they will be working with them together and separately. So we're going to be trialling that project. We secure some external funding for that, and then hopefully we'll be able to try and take this forward and try and do it and expand it to our program. Now, we do have some training with our solace providers. They deal with floating support, which is what we call medium and standard risk. So we do have a training program that's currently taking place. What we need to do is look at expanding that program to our high risk victims as well, and having a much more holistic approach. But we definitely know that training for the parents and the children underpin some of the work, and try and decrease some of the incidences. So it's on our radar, Beverly. So I'm happy to join that discussion with you and Chantal.
Thank you. Thanks very much, Manju. Seb.
Hi, Ryan. Just put my mic on. So Chantal's presentation was brilliant. We've had a lot of really good, I think, conversations, collaboration with Haringo and the VAW partnership. So it's been really positive. I just want to dwell a bit more in terms of the police activity in this area. So what I'm going to try and do, hopefully it'll let me share it. Does my screen, does it come up on? I've tried to share the slides.
Showing, Seb.
It is showing, good.
Yeah.
So this is police information, police dashboard, NPS data, and it shows the entire Met. And if you see the bottom columns, you'll see some columns in colour. Can you see my arrow hover over one of them?
Yeah.
So these are the 12 basic command units. So London is split into 12 territorial areas. I cover North area, which is Haringo and Enfield. And this arrow, the green, the light green arrow column would represent North area. So that's Haringo and Enfield. And what the column represents is just use of DVPOs, Clare's Law disclosures, merit referrals, corns. There's also stalking protection orders that we use as well. But I think what it does, it just highlights very crudely our approach in North area in relation to DA. So working back to even, I've read many HMIC reviews, they take a more holistic, multi-dimensional approach to DA, in that you don't just look at your charges and your cautions, but actually what steps are you taking to prevent or disrupt domestic abuse? And we've embraced that. And one of the key points from the HMIC is that as police, we're in a unique position when we've got powers that we can use and utilise. We can arrest people, we can present cases to the CPS, we can take people to court. So it's really, for us, maximising use of those policing powers to really disrupt and prevent DA. So that's something that we've been doing for the last 18 months. Whilst I've been here, we've been really driving that. And what you can see is of the 12 BCUs, the light green one here is us. We're way ahead of the other BCUs, just in terms of our use of DVPOs, Clare's Law disclosures. There's work to improve around merit referrals. You've got corns listed there, although that's more to do with children exploitation. But if you were to add also stalking protection orders, we're way ahead of our other BCUs in terms of that. So it is paying dividends in terms of our approach and maximising our use police powers to prevent and disrupt DA. And we are seeing a tangible impact. It's a bit like driving offences. So everyone, there was a time no one wore a seatbelt, then there was a lot of enforcement, a lot of education, and now it's unusual that people don't wear seatbelts. So not trivialising DA to that extent, but I'm just saying the same way that you can influence culture by really driving this area of business. So that's what we're trying to do. What we found, which was really good feedback from Bridie and Chantal, was that there was gaps in terms of the policing approach. So what we were doing all this work around prevention, but the link up, the join up with our partners and that multi-agency problem-solving approach, there was some real gaps in that in terms of a disconnect. So I formed the ADAPT team. So we've set that up. It's in place. We've got a brilliant, Michelle Fordham is one of our brilliant managers leading that. And what that is a bridge. I'm really keen around procedural justice. And if victims, just as important for them to the disposals is the fact that they get the agency, that they're heard, that they're treated fairly, that they're given updates appropriately, and also the IDVAs and the various partners that work with them also have that information at hand to give to them. So our hope is that the ADAPT team will fill that gap that I think is really important in terms of procedural justice. So I think overall really positive. I think what's been brilliant in Haringey is the multi-agency plans that we've got in place. So we've got the VAWG plans, and if we had time today, I'm sure Chantal will touch on how we've got a plan for each agency and how they drive VAWG forward. But I just want to share with you some of the highlights in terms of the policing response to DA.
Thank you, Seb. That was really helpful. And I think we applaud and really value those efforts to disrupt. And it's really clear in that data that you're sharing with us. So thanks for being so open and sharing that. Does anyone else have any more comments, questions, or observations? Okay, no. I think that's because it's such a thorough piece of work, and I hope everyone sees the commitment that the council's made and that Seb and his team, that everyone's made in actually really diving into some of the detail of these issues and really wanting to tackle them. So thank you, everyone, and thanks for the presentation, Chantal. There's still plenty of work to do, so that's why we're all here together. So I think I'm going to take us on to the next item, please. And I don't think we've got a presentation to share. This is the anti-racism and tackling health inequalities, and Christina's going to give us a verbal update.
Thank you, Councillor Desnev. So I do have some slides to share, if that's okay. Yeah, so I'll talk through these, and I'll bring Jeffrey in as well, who's going to cover an update on the racial equity and health and care group that was recently established. So let me just try and maximise my screen. Okay. So yeah, I wanted to give an update on the progress so far across the eight themes in the programme plan addressing racism and racial discrimination. Thought it'd be helpful to pull out particularly the progress in the community safety and policing theme, because that kind of straddles work in the Health and Wellbeing Board and the Community Safety Partnership. As I mentioned, Jeffrey will give an update on the racial equity and health and care group. Wanted to touch on some theory of change work that we're doing at the moment to review our objectives across the plan, because we committed to doing that at the last one of these boards. And then touch on the community networks that we've established recently, and then space for kind of questions and discussions. So diving straight into the updates on progress across the plan. We had our last coordinating group meeting, which is the kind of first layer of governance that we have for the plan, in May. And we use that to kind of pause and reflect on the 2-year anniversary of George Floyd's murder, and to think about the progress that we've made since the plan came into being, and try to formalise a bit more a framework for the activity we've been delivering, which has been, I think, driven by a lot of enthusiasm and motivation, and has grown quite organically, but wanted to use the theory of change process to just to make sure that we've really thought through what we're aiming for and what we need to do in order to get there. So kind of going clockwise around these bubbles. So this is just a bit of a whistle stop of some of the key bits of progress we've made across the whole plan. So we have been working with the BAME Equality Working Group, which is co-chaired by our lead commissioner for adult mental health and one of our local GPs. To kind of draw together data on mental health in relation to people from ethnic minority backgrounds in the borough. And we pulled together some really useful, robust data on disproportionality in our mental health system, particularly focusing on the use of Section 136 and the fact that we see a really high proportion of use among our young Black male population. So I'll come back to speak a bit more about that in the update on the community safety and policing theme. But just wanted to highlight that that we'd worked really collaboratively with the trust. They've been incredibly open with the data that they had to share, and off the back of that, got more really rich data from the police, which took us to more of a granular understanding of where those section 136s were being used. We have also, under the policy and strategy theme, reviewed the categories being used for ethnicity and nationality in our equality monitoring form. So the policy and strategy team really led on that from the council, and that was informed by the ONS standardised categories, so making sure that we were reflecting those so that we could be comparable both regionally and nationally. And they did quite a bit of engagement as well with local stakeholders to ensure that the categories felt fit for purpose. So not only were they reflecting the ONS picture, but just making sure that local people and communities felt like it was reflective of them and their experiences. So we're now in the phase that was signed off by Statutory Functions Board, and we're now in the phase of kind of rolling out the use of that updated equality monitoring form and thinking about how that can be used across the partnership as well. In our education and attainment theme, we have delivered an Equal Start project at Lee Valley Primary School. That was heavily led by Jeffrey at Bridge Renewal Trust, as well as colleagues at North Mid, and that saw the delivery of laptops and data to children who didn't have digital access over the pandemic. Really successful project. So I think we saw engagement in homework jump from 13% to over 90% among those young people who were kind of most in need of the support. And the follow-on phases of that project saw us introduce connected communities drop-in sessions at the school, so trying to provide more of a kind of wraparound support model. We also had some mentoring sessions from a local organisation with a group of children who were deemed to be kind of most in need of additional support, and that was also really well received by the young people. So yeah, that felt like a really good model developed there, which had additional funding attached to it. We've established a number of community networks over the last 18 months, and again I'll come back to those kind of towards the end of the presentation. And then again, in relation to the work that we've been doing through that BAME Equality working group and the mental health understanding, we secured 43,000 to deliver a mental health first aid training to our local police service through Mind in Haringo. So I'll talk a bit more about that shortly. We held our first diversity in the public realm engagement meeting with partner and community stakeholders. So this was really triggered by the Commission on Diversity in the Public Realm, which was established by the Mayor of London. And then we kind of responded locally. We've already seen some work done around sort of public space name changes and street name changes, but recognise that we needed to have a more kind of strategic approach to that. It's not just about kind of renaming, but also how we understand our local heritage, what that means for kind of discrimination throughout the system, how that translates into education, and things like safety in public spaces as well for different protected characteristic groups. So we'll be looking to organise the kind of follow-up session to that first one in the coming months. Wanted to pull out that we've had a number of teams across the council really kind of pick up the equality agenda or equity agenda and run with it. So the urban regeneration team has developed their own guidance on EDI in procurement, so equality, diversity and inclusion in procurement, and we're working with other teams to see how they might be able to adopt that once it's kind of formalised. I know there's some great work going on in public health under Will's oversight, looking at kind of recruitment and retention, excuse me, and equality within equalities within those policies and approaches. So really good kind of self-motivated work happening across the organisation, which is great. A couple of months ago, we ran a workshop on our partnership response to hate crime in collaboration with our faith communities. So this kind of falls under the faith and identity theme in the partnership programme plan. And launched the council's anti-discrimination campaign last autumn as well, to try and encourage people sharing their stories, but also coming forward to report when they've been when they've experienced hate crime. And again, just another good example of a service developing a really positive piece of work around equity is the Park Service. So they've started a pilot using an equitable recruitment model, so looking at how they really reach out to our diverse communities to get them to come forward and apply for jobs, but the support that's often needed to kind of get people excuse me, get people into those roles and keep them in those roles, and making sure that it's a good experience all round once they start employment with us. So the community safety and policing thing that I've mentioned a couple of times, as I mentioned, we had some really helpful data shared with us through BEH, which, as I said, was further supplemented by the police. So that really highlighted the disproportionality in the use of Section 136, particularly with young black males. The police were then able to kind of break that down to a postcode level, and also look at how that picture had changed pre-pandemic, kind of first phase of lockdown, and then as we've moved through coming out of lockdowns, I suppose. And we've had a number of meetings with police colleagues. So Lynette Charles has been a fantastic leader on this piece of work, and has worked with various police colleagues who've been involved. There's been quite a bit of churn on the police side over the last year, but brilliant engagement from them. And yeah, a lot of enthusiasm to take the work forward. So we'd initially thought about trying to secure funding to have a mental health professional going out to calls with where police are called out on Section 136, which is basically a section of the Mental Health Act which enables police to detain people when they are in mental health crisis. But we kind of spoke to a number of partners about that, and reviewed some other pilots that had been run around the country, and started to question how much that would actually help, particularly with the sort of racial disparity element, and it was felt that maybe that wasn't the best approach. So we've worked to develop a pilot project which instead would deliver first mental health sorry, I'm struggling with a bit of a tickly throat at the moment. Mental health first aid training to Haringo police officers. So Lynette has now got 12 two-day sessions booked in over the next 6 months with local police using that 43k funding, which was fantastically identified by someone called Michael Chalmers at BEH through Health Education England. And I think around 100 officers have signed up for that training so far. There are 200 slots available. So that we're pretty early days with kind of getting the communication out to the officers, but really positive kind of initial signs there. And that will have quite a heavy focus on kind of cultural awareness as well, and understanding our local communities, making sure that police feel comfortable engaging with excuse me, with different groups, and importantly developing a better awareness of their own mental health needs. I think something we collectively recognise was the impact that dealing with traumatic situation after traumatic situation has on officers, and if they don't have the space and the tools to be able to deal with the experiences that they're having, they're carrying that into the next interaction that they have when they're called out. So really important for them to be getting the support they need as well. So that feels like a really positive piece of work that's been a long time in the making. We've been having discussions for a while now, but we're at the point of getting those training sessions going, and we're developing the kind of evaluation framework that we'll be using just to see what the impact is, both for police officers, but also thinking about how we measure that for people who are experiencing being sectioned, but also the local support services, so the ones that are based in the community, that officers will also get training on awareness of the different services that they can signpost people to when they are experiencing crisis. So hopefully off the back of this, we'll see more people being referred into community services as opposed to being detained and taken into hospital. So at that point, could I pass over to you, Jeffrey, to give an update on the Racial Equity and Health and Social Care Group?
Thank you, Christina. I'll do the one slide, then I'll pass back to you. Yeah. Okay. So this particular slide is about, as you can see, is about kind of racial equity in health and social care, and like you've heard from Christina, there is really a lot, and quite rightly, inequality and structural racism. It comes across different areas of work and where residents come across different services, and that's not just in health, but it could be other areas, education, policing, like has been described here. But we thought that there was a particular gap potentially at focusing on health and social care as an area really, and some of this was driven by a report from the NHS Race and Health Observatory report, which was in February this year, which looked at which confirmed really what I think we all know, which is some of the ethnic inequalities in terms of access, experiences, outcomes, and so forth. And that some of that could be around just treatment. For example, if you take, some Black mothers and the maternal treatment and care they receive is quite different. There's also something around workforce there, but there's also something about other the lack of ethnic data really, so that we can monitor. So what we're trying to do here is to kind of focus on the health and social care aspect. So this group really is about considering all of those aspects as it applies within Haringo, but also then providing a forum where clinicians and non-clinicians, practitioners and others come together to have a constructive discussion. Is not to oversee anybody's work, but I think how can we helpfully work together and share good practice. And hopefully then take the lead in terms of identifying some of the gaps and how can we address those gaps, I think working collectively. And lastly, really aligning what we all do in our different organizations together. So as you can see here, we've had one meeting so far, which was the group is called chaired by Nina from Northmead and myself. So the last meeting was on the 22nd of June. The next one is quarterly. There's about 3 or so in a year. So it's not a lot, but we want to try and do things in between, obviously. The next one will be in October and another one in February. In terms of the focus of work, we're looking at access, I think is a big thing. And what does the data tell us and what are some of the issues there? And we want to be able to, and we do include digital access, because you may well be digitally able, if I can put it that way, but you still struggle in some areas, I think, to book yourself into different places. The other thing we want to look at also is the workforce diversity and the data and the insights around that. The third area, which is really, some of you will know this probably better than I do, which is something called Core 20+5 themes. So it's these additional themes that is really important in terms of checking out, particularly within the NHS, but also others, how we are doing. And the 5 areas we want to focus on is maternity, as it says there, and trying to make sure that we have at least continuity of care for 75% of women from Black, or so-called BAME background, because there's a particular issue there. The second thing is on SMI or severe mental illness. Again, we're setting some sort of targets of 60% of those living with SMI being in line with, for example, we are including there, but by the way, we're also including stuff around learning disabilities and so forth in terms of the impact we are trying to achieve. The other one is chronic respiratory disease. I think we want to have a clear focus on COPD, but there's also others around vaccination, driving us flu, and other, COVID hasn't gone away as well, which we've seen a lot of work needing to be put in there. And there's something also about avoiding, emergency hospital admission in all of this where possible. Early cancer diagnosis is another important one. Again, we've got a target there that needs to be, these are national targets that needs to be achieved, and we want to make sure that the data that we get from a racial perspective are also up there where it needs to be. And lastly, hypertension, or the case finding around that, is also another important area we want to do. And this will require clinicians, but also require all of us coming together to be able to kind of make sure that we address any structural, systematic and other inequalities that may exist in the borough. So that's what it is, and we'll be reporting back to the Addressing Racism Coordinating Group, which is, this is just one strand within that wider strand, as Christina has been explaining. So Christina, can I take back to you? Thank you.
Yes, thank you, Jeffrey. That was a welcome break, thanks. So yeah, just to come back to the theory of change approach I mentioned, at the last joint meeting of this board, we committed to reviewing the activity across the plan using a theory of change model, just to make sure that we were aiming towards the right long-term objectives, and we had all the right actions in place in order to get us there. So as I mentioned before, at the last coordinating group meeting that we had back in May, we used that to kind of kick off that theory of change planning and review. So each of the each of the theme leads went away and started to think about the kind of long-term objectives that they wanted to work towards in their specific thematic area. And we're now in the process of doing kind of follow-up sessions with each of those theme leads, and we'll bring the discussion back to the next coordinating group meeting we have, which will probably be around the end of September. So I think by the time this joint board comes together, excuse me, we'll be able to update on the kind of finalised long-term objectives and the action planning. So why did we choose to use a theory of change model? It helps around kind of strategy and change, so helping teams and partnerships work together to achieve a shared understanding of a project and what its aims are, makes projects more effective by clarifying aims and goals, and helps bring risks to the surface. Something that we were really keen on was measurement, so helping to determine what needs to be measured through evaluation activity, and encouraging teams to think about the evidence about what does work, and surfacing untested assumptions about this. Communication is another area it helps with, so enabling us to quickly communicate a project's aims, especially using diagrams, so just kind of quick glance, easy to understand and digest, and brings the process of change to the forefront. Also helps with partnership working by clarifying roles and responsibilities and establishing consistency about outcomes. So we felt it would be a simple but robust approach to take. So as I said, following that workshop that we had at the last coordinating group meeting, we're following up with the theme leads on a theme by theme basis, and then we'll come together to collectively discuss all the draft theories of change and reflect on what they might mean for how we prioritise going forwards, how we work together, and I think really importantly, alongside that evaluation piece, thinking about what's actually needed to enable the successful delivery of the plans in terms of kind of resourcing in particular, but also partnership working and ways of working. So that's the theory of change work. And then lastly, just wanted to give a quick update or flag really the community networks that have been established over the last 18 months and beyond. These have involvement and or facilitation from the council and partners. So the three that I'm quite directly involved with are the Turkish and Kurdish Community Network, the Somali Community Network, and the Eastern European Community Network. And then we have another three that are kind of facilitated by our voluntary and community sector team in the council, so the Latin American and Latin Caribbean Community Network, a Women's Community Network, and LGBTQI+ Community Network. I'd say that the networks, at least the three that I'm directly involved with, are at relatively different stages. So the excuse me, the Turkish and Kurdish Community Network was established about 18 months ago, and it feels like we've built a really strong set of relationships across those organisations and individuals that attend. We're kind of at a point where we're joining up with different pieces of project work and programmes and thinking about drawing in funding, and getting down to how we might evaluate what we're doing through the network. The Somali Community Network, for example, just had its first meeting in February of this year, and it feels like we're still kind of feeling out the ground and working out exactly how that's going to work in terms of facilitation of the network. Similarly, the Eastern European Community Network had its first kind of formal meeting earlier this year, and we've had a number of conversations, probably stretching back to last winter, in the build up to getting that off the ground. But I think the invasion of Ukraine and our local response to the Ukraine Homes for Ukraine scheme really kind of sped up the establishment of that network and probably got more people involved, which it in one sense was really positive. I'd say across the piece, all of them, we recognise the need to have a sort of platform for engagement where statutory services and partners could come together with community members and organisations to kind of build trust, better understand what the key issues and strengths are, and identify opportunities for kind of influencing decision making and working together better. So I'd really just like to plug the fact that we have all of these networks, and if there are big bits of work that you or your organisations are involved with, or opportunities, so things like job opportunities, really good to kind of push these out through the networks because their tentacles kind of go far and wide into the community. But also being mindful that having these networks it's one layer of engagement, so it's not quite the same as kind of you know, feeling like we have solid direct relationships with the Turkish and Kurdish community as a whole. We recognise that it's kind of specific organisations that tend to come forward and attend these meetings, but still really positive to have these platforms for engagement, and I think they've been really well received by all of the various communities that we have established them with so far. So that was it from me, and happy to take any questions.
Thank you very much. A long presentation, but actually some really important detail there. I had a few questions. One, going back a little bit further nearer the beginning of your presentation, Christina, on the Lee Valley Primary Project. I wonder, sounds like some really interesting stats and impacts and outcomes coming out of that. And I'm wondering what the plan is in terms of writing those up and then being able to share those and think about how we would translate that into across the borough. So that was my first question. And then I had just a couple on the Racial Equity in Health and Social Care group, Jeffrey. Just a little bit interested in the makeup of the group and what you're looking at and where that started and how that might evolve if that's appropriate. And just thinking that some of the things you're listing there really connected with recent presentations are on Healthy Start, and that's coming up at Health and Wellbeing Board, I think. So I think there'll be some interesting synergies there. And no doubt those are conversations that we're already having, but and others might want to say something more about that. And then the only other thing that I was thinking about was that in the context of that group was that localities and neighbourhood sort of level approach and thinking around how we engage different communities at our neighbourhood and localities level and how we recognise some of the barriers. So those were just a few from me, while everyone else thinks if they've got any.
Okay, Christina, shall I answer the first two, I think? The one about the Equal Start and the Lee Valley.
Yeah, happy to say that.
And potential scaling up of that. And also the makeup of the racial equity group. And then I'll leave the rest to you. Okay. In terms, there's something, why did we pick Lee Valley, for example? And this started in the depth of lockdown 1, where, there was, children not participating in school activities because they didn't have digital devices. So very helpfully, NHS partners and the council each gave £1,000, so it added up 40k, something like that, which we then used to get some, devices for the laptops and so forth. And alongside that, because they were just not, participating at all, and like Christina said, the participation jumped from something like 13% to, almost 90-something% in terms of participation. Now, the whole idea was that we would then use this as a kind of a pilot to see, because then you begin to go beyond why are they in this situation. And that's why Connected Communities has now come in to try and address some of the other, issues that is impacting on why they don't have this equipment and so forth. And we are finding, stuff around housing benefits and different advice, employment, and all of that. English language is a problem. So from September, we've got Haringo Lands, the new HAL service, also providing ESOL classes for parents, for example. So this is now in terms of scaling this up and mainstreaming it is going to depend on funding and resources, obviously. But it would really be good to take this to other schools as well and neighborhoods. Now, there's been an evaluation done, which we will be able to share with people here, and also, and the membership of whether it's the Wellbeing Board or both, really. So we can share that in due course as well in terms of learning. The makeup of the group is a bit fluid, but again, we didn't wanted it to kind of have a mix of operational people on the ground, no disrespect to people on this call, yeah, but also we wanted some level of, obviously, people who are into policy making and so forth. So we tried to get not to be the kind of same group of people coming together, really. So we got people from mental health, all of the EDs, equality, diversion, and inclusion leads within the NHS Trust and the Council, as in Christina, are there. But also we got clinicians, we got GP Federation, we got at least 2 primary care network GPs. We got people from the hospital trust there as well. We got voluntary sector. We got our council colleague. We got Will from and others from public health. Because the idea is to have both practitioners, I think, and also some representative thing. So just to read then: mental health, social care, voluntary sector, primary care, secondary care, and community services. So that's what we have there. And I think that answers your question, Chair, isn't it?
I think so. I was just interested in the context of how we look at things both through different lenses. So I was interested in how what you might connect with that when we look at neighbourhoods, when we think about place-based and localities, and then we think about some of our racialised and minoritized communities, the interplay between those two things, where you live and then who you are, and how that might affect some of your outcomes too.
That's helpful. Thank you.
Christina, I think you've covered everything. I just think that Lee Valley really makes I think it'd be really, I think it'd be good to see the evaluation and to make sure that's shared quite widely, and also the councils, etc. Just so I take your point, we can't do anything else unless we have funding. But then, if there's a strong case and we share that widely, that might help with the funding, mightn't it?
Yeah, but sorry, Chair, one final thing is we're trying to bring a lot of funded services in. I think I've talked about, the adult learning service. I've talked about connected communities and others. So just to keep it going as well. Thank you.
Yeah, no, it sounds great. No, I think and that's what's most interesting to me about that piece of work, is how it grows into something greater, which has really, really big outcomes. And when you were talking about that, I'm thinking about, because I, as a counsellor, I hold road grading surgeries in primary school, and it's exactly that. That's what I pick up on, is those things, those issues that schools often know are going on for families, and nobody else really knows for lots of different reasons. People haven't been able to access services. And I know Councillor Browerson's on the call, and she'd always say that sometimes school is the only place where people interact with any structures for loads of different reasons. I can't see any other hands up, so probably was just so thorough, Christina, that everyone's just really supportive. I wanted to say something that I didn't mention earlier that came up I thought about it in both 2 previous conversations we had. and it's because I'm seeing you as well, Christina, at the same time, is that that element of the migrant and refugees and impact. So the first conversation we had about drug and alcohol and the context of that and that relationship and interplay, and also no recourse to public funds and how that affects just how you generally interact with all sorts of services. And then also, of course, that's a really important context in our conversation about violence against women and girls. So I want to lose that. And of course, we've got the Welcome Board that can hold some of those conversations as well. But I think it's probably really relevant to everything we've talked about here today, really. So I think we've come to the end, and unless anyone's got any other comments or any other business. So this group is meeting again in January 2023, but I think I'll see all of you, you know, not quite in the next few hours, but nearly, and the work continues in between times. Thanks all for your presence and your input and thought on this work, and we'll carry on unless anyone's got anything else they want to bring up or pick up. I don't know if we've got.
I can see a hand up, Chair. Yeah.
It's only you, but Councillor. I didn't want to disturb the meeting, but Councillor Joggi did say that he did send his apologies for this meeting, so I'd just like that to be formally noted.
Okay, thank you. Thanks.
Thanks.
Somewhere that message got lost in the ether, not to worry, but thank you. Thanks very much. Okay, well, thank you everyone, and see you all soon. And take care. Enjoy the sunshine.
Thank you,
Thank
Chair.
you.
Thank
Thank
you.
you.
Thank you.
Thanks for having me.
Bye-bye.
Thanks for having me. Bye.
You're welcome.
Thank
Thank you.